So the next speaker is Dr. Rajesh FOGLA, a senior consultant and director of the cornea clinic at Apollo Hospitals, Hyderabad, a very leading figure in cornea and anterior segment with a great international presence, a great surgeon, and he is going to talk on phakic IOLs in keratoconus. On to you, Dr. Rajesh. We look forward to learning a lot from you.
My slides are visible?
Yeah.
Yeah. At the outset, I would like to thank Dr. Chitra and the ARC AIOS for inviting me to be part of this exciting symposium. And it's nice to learn quite a lot from the masters in phakic IOLs. So the topic given is toric ICL in keratoconus. I don't have any financial interest in this presentation. And the first question that we ask is there a role for phakic IOL in keratoconus? We heard Naren talking about the contraindications, and one of the last slides he showed was a patient with keratoconus, and where he said that, maybe this raises a red flag and you should not consider a phakic IOL. And in fact, if you look at the indications from STAR ICL, even they don't recommend in the indication for any patient with keratoconus. So it's actually an off-label use. Now, looking at a patient with keratoconus, we know that a patient of keratoconus has a lot of induced high-order aberrations, typically the coma, and this results in visual degradation, and that can result in dissatisfactory vision. And in a majority of these cases, a satisfactory vision is achieved only by using a rigid gas-permeable contact lens. Keratoconus is a disease which can progress over time, which means your refractive error and the astigmatism can change. In advanced cases, you can develop eye drops, and patients may require corneal surgery in future. So taking all this into account, is phakic IOL an indication? But if you look at the published literature, you will find that there are numerous articles which talk about successful outcome using phakic intraocular lens implantation, either in combination with cross-linking sequentially, or with doing topographic guided surface ablation or placing intracorneal ring segments. So using a varied combination, people have been able to use the phakic IOL to try and achieve good vision in patients with keratoconus. We already heard various speakers to give us details about the phakic IOL. The two varieties which have been reported in literature are the Verisize and the ICL. The basic indication would be any patient with keratoconus where the best spectacle corrected visual acuity is 612 or better, and the patient has to be happy with this 612 vision. It shouldn't be like patient has to strain to read that 612, but the patient should be very comfortable. The astigmatism should be less than 6 diopters. The keratoconus should be stable and non-progressive. Sometimes you need to do a cross-linking prior to considering the phakic IOL. And the other criteria for phakic IOL have to be met in terms of the endothelial cell count, the anterior chamber depth, and so on. In terms of surgery, there is no specific step that you would like to see. This is an old video of a patient who has already had an intracorneal ring placement, and now the patient is undergoing a toric ICL implantation. So the basic surgical steps are the same, where you mark the axis, fill the chamber with viscoelastic, and then you implant the phakic IOL. This is a toric ICL being implanted. This is one of the cases where you will see a patient who has a moderate keratoconus. Astigmatism was about 3.4 diopters. His refractive error was 9.5 with -2 cylinder, improving to 6.9, and we implanted a toric ICL. And the post-implantation AR value, if you see, is about +1 with some +0.25 cylinder. And his vision, unaided vision, improved to 20/30 or 6.9 at a vault of about 600 and good endothelial cell count, and maintained that at long-term follow-up. So this is what we had presented back both at AO and ASCRS, and we analyzed 36 eyes of 24 patients who had undergone toric ICL implantation. The mean age group was 26 years, ranging from 17 to 40. 12 of these patients had bilateral procedure. The average follow-up was about 13.7 months. The average pre-cross-linking K was 51 diopters. Post-cross-linking was also the same, no progression. Had good specular counts, and anterior chamber depth on an average was about 3.9, which is expected in patients with keratoconus. The average pachymetry was 461. But what you see is that the unaided vision from 2200 went up to 2040. And the number of lines of improvement, if you see, on an average, 44% of the patients had 7 lines of improvement in uncorrected visual acuity. Even the best spectacle corrected visual acuity from 2040 average improved to 2025. And that's expected because the ICL is placed closer to the nodal point. And so these are a subset of patients who did very well with the toric ICL. Now, coming to how do we plan? I've shown you that yes, toric ICL can be done. It does work in keratoconus. So do you go ahead and do it in each and every keratoconus patients? No. You have to look at the location of the cone. The cone has to be fairly central. There should not be a significant amount of superior-inferior asymmetry. The keratoconus should be stable. If you are in doubt, then please do a cross-linking first. And then 3 to 6 months later, you can plan for a ICL implantation. Take into consideration the pupil size as well. In our population, the pupil size is a little small, so that's to our advantage of our patients. Dark colored iris also helps. But if the mesopic pupil size is large, it's beyond 5 millimeter, then maybe it's not a great idea to implant a toric ICL in patient with keratoconus. Understand the patient's expectation. Explain to the patient that the vision would be the same or slightly better than what they can see with the spectacles, but not as good as what they can achieve with the rigid contact lens. Spending time before you perform the procedure is helpful because it can avoid disappointment post-procedure. Often we need a combination of procedure, like either doing a cross-linking followed by the toric ICL. Sometimes we do a single segment intact ring placement to lift up the sagging cone and make it central, and that helps. If the corneal thickness is more than 470 microns, we can do a little bit of topography guided surface ablation to try and regularize the surface. And
1 minute remaining.
Yeah, so I'm coming to an end. And a majority of these cases had high myopia as well. So the toric ICL helped in reducing the myopia and their dependency on wearing the contact lens. So this is again some of the topographies you can see. So this is a patient with early keratoconus. This is one eye early, and the other eye, you can see it's a fairly central cone. So these are great patients. This is a patient who had an inferior cone. We placed an intact, after which you can see that the cone has become fairly central and the astigmatism is reduced. So in this case, for managing the myopia, you can consider a toric ICL implantation. So basically, in conclusion, phakic IOL such as toric ICL can be considered in select cases of keratoconus for visual improvement. Please remember, it's not a refractive procedure, and this needs to be explained to the patient. It's important to understand the patient's expectations prior to the surgery. Luckily for us, toric ICL is a reversible procedure. So if a patient is not happy with the outcome, the toric ICL can be explanted and the patient can go back to the refractive error what they had earlier. Thank you. Thank you for a patient hearing.
Rajesh, I'm going to take questions with you because being a cornea situation. Now, what would be the extra thing you would advise when it comes to sizing of the lens in a KC patient? What would you tell your company guys?
So usually I've not had any issues in terms of sizing if I take white to white and I implant an ICL, because here the anterior chamber depth is adequate. So even if your lens is slightly oversized, it doesn't affect the outcome. But if you look at the average vaulting that we achieved in our series of patients where we did the toric ICL, we did not achieve any high vault. The maximum on an average, the vault was between 400 to 600 microns. And that couldn't be taken into account that the anterior chamber depth was much more than what the nomogram does for that same amount of white to white diameter in patients with keratoconus. and we did not do it in very advanced keratoconus. So the keratometry was not very steep. On an average, it was only about 51 diopters.
Dr. Ramamurthy, would you want to add?
Can I ask a question?
Yourself? Unmute yourself. The question was sizing
great.
of the lens.
Yeah.
In
Can I-
case-
Great presentation, Rajesh. I mean, just a comment is that we have come to grief on a couple of occasions when we have gone by the regular sizing and implanted a lens. When we send the company to the company only the central anterior chamber depth, because as was discussed earlier also, you could have a central cone and you get an extraordinary measurement over there. While in the periphery, the cornea tends to flatten out. And nowadays, what we have started doing is earlier implantation in a case of keratoconus is off-label as far as toric ICLs was concerned. So our experience was more with toric IPCL. Now with ICL also it's possible. So we specifically mentioned to the company it's a case of keratoconus. Often they also realize looking at the K readings. And normally we undersize by about 0.25 to 0.5 millimeters. And we find that it works reasonably well in these cases. And you summed it all up, but just to say, you have to look at the centered stable cones. And often I'm asked, how do you know it's a centered cone? You look at the posterior floor. The nipple of the cone or more than half the cone should be within the central 3 millimeters. And when do you go ahead and implant a toric phakic intraocular lens in a case of a keratoconus? If the patient is happy with the best spectacle corrected visual acuity, the patient is dependent on contact lenses. Please do not implant a phakic intraocular lens because there is quite a bit of higher order aberrations which the phakic intraocular lens will not take care of. There have been 2 occasions where we had to expand the lens because the patient did not accept it. What will happen is whatever power you put in the lens, that amount of correction you would have to put in the spectacles after putting a contact lens. So it's not as if you can rehabilitate the patient after putting a phakic intraocular lens by putting the same kind of rose scale lens or a scleral lens on the cornea. It will not work. So please be very sure that the patient is happy with the best spectacle corrected visual acuity before considering a toric phakic IOS.
But if a patient has a mildly decentered cone and his spectacle corrected vision is good, would you, what
Yes.
would you?
We have done a study on that also. We earlier used to
Wanting
strictly
to ask Rajesh his thoughts on that. Sorry.
Sorry, okay.
Yes.
Oh, in the sense that it's not exact, it's not an exact science, you know. Sometimes we see patients where you look at the topography and you find that despite with that kind of topography, some of these patients with spectacles tend to see quite well. And in fact, quite a few quite a few occasions, I have personally put in the value to check if the patient is actually reading that much, instead of believing what my optometrist has written, you know, because sometimes they may, the patient may miss out some line. So if the patient's spectacle corrected visual acuity is definitely 612 or better, 6.9 he can read, then I don't worry about that little bit of decentered cone. So because that has to do with something to do with the pupil not exactly being in the center, the angle kappa, or so we go ahead and do the ICL. But all the patients that we do the ICL, we always explain to them that this is an off-label procedure. We do it. If you are not satisfied, there is an option that the ICL can be explanted.
But if
So
the
which
subject, yes, Naga, you asked.
Sorry, ma'am.
Yes,
No,
Naga.
just wanted to ask, sir, lovely presentation as always, so clear. So just wanted to ask, which K reading do you take for these patients?
The readings that we get on the topography.
So from the topography.
Correct.
Now, if the subjective acceptance, the subjective acceptance and the cylinder which is showing on the topography are in variance, what would you take?
No, usually we go by the subjective refraction only. We don't look at the K reading. But like I said, that before we go ahead, it's important that the surgeon should always try and verify, you know, although you may have excellent, at least for me, my optometrist does it, but I have this finicky thing about me going and just checking the axis once again. And I find that that really helps, you know, when you are doing the surgery in terms of the outcome.
Yes, Dr. Ramamurthy, I'm sorry, I interrupted you.
No, I quite agree with what was being said. Initially, we used to strictly go by the fact that the cone has to be centered before going ahead and implanting these toric phakic intraocular lenses. But obviously in gross decentration, they won't improve with glasses. But minimal decentration, if the patient is happy with the, so basically what we go with the best spectacle corrected visual acuity. If the patient is happy with glasses, go ahead and implant a phakic intraocular lens, toric lens.
And thanks, Rajesh. That was a wonderful talk. And the punishment is you stay till the end.
In fact, when I did my first toric ICL for a keratoconus patient, having treated keratoconus patients for so long, I was so apprehensive because somehow the science I couldn't believe that you have a deformed cornea and where you have abnormality in the optics, how is the ICL going to improve the vision? But then looking at the outcomes, it was quite gratifying. And the patients with keratoconus are not as finicky as your refractive patients because they are used to seeing so much of distortion. For them to be able to see 612 also unaided, they are far happy than somebody, looking at, 0.25, 0.5 residual power and not being able to see very well.